Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Today, we are quite privileged to have Brian Swanson joining us. Brian is a seasoned researcher and will be discussing with us today the reliability and validity of cervicothoracic differentiation tests in the treatment of individuals with neck pain. Brian is a physical therapist with over 20 years of clinical experience. He is a board-certified orthopedic clinical specialist and has completed extensive manual therapy training, including receiving his COMT through Maitland Australian Physiotherapy Seminars and a fellowship in orthopedic manual therapy focused on the Norwegian approach through the Institute of Orthopedic Manual Therapy. Brian received his Bachelor's of Science in Physical Therapy from Quinnipiac University and a Doctorate of Science focused in orthopedic manual therapy from Andrews University. He is currently an assistant professor in the Department of Rehabilitation Sciences at the University of Hartford. Brian, welcome to the American Academy podcast. I'm excited to have you join us today and have the opportunity to converse with such a seasoned researcher. Let's just jump right in. What I'd ask first, can you give us the title of your study as well as where it's at in its route to publication?
Sure. Well, first, thank you for inviting me. It's a pleasure to be part of the podcast, and I'm excited to share some of my research with the Academy. The study is titled Reliability and Diagnostic Accuracy of Cervicothoracic Differentiation Testing and Regional Unloading for Response to Thoracic Manipulation in Individuals with Neck Pain. The paper at this point is in the revision process, so we're hopeful that it'll be coming out sometime relatively soon.
And what journal did you submit it to?
So it is currently with the Musculoskeletal Science and Practice.
Well, I wish you luck on that. I know the research publication process can be tedious. How many edits have they sent you back with so far?
I believe we're on revision number 3 right now.
All right. That's not horrible.
No, not horrible.
This is not your first rodeo. You've done research in the past. Can you tell us a little bit about your background in research and how you got on this track and some of the stuff that you have published already?
Sure. My research path, I think it came from the same direction as many clinicians. I was a practicing clinician for about 18 years before I went into academia. And my big push to actually pursue the academic route was I had so many clinical questions that I couldn't find answers to and that weren't published in the literature. And so I decided it was time to figure out how to answer some of my own questions. And so I took the route of, for most of my research, trying to answer the relevant clinical questions that we've had. And we have this huge body of very elegant, very eloquently described biomechanical tests and measures and things that appear to have great face validity. But when you go and look in the literature, there's really no evidence to support the assumptions that the authors have made when they first presented them. And so my work to date has in large part been looking to validate some of our orthopedic manual therapy tests and measures. So my previous work has looked at particularly lumbar unloading as a predictor of response to lumbar traction, and the current study as well, looking at regional differentiation testing, trying to decide who may or may not improve following thoracic manipulation.
Your time and effort in that area is so valuable, as we all know that PT has so much to offer, but much of the things that we do are not validated in the research. So I totally appreciate folks who spend the time and effort to get into research like you're doing. Are you doing any patient care at this time, or are you mostly research?
Right now, I'm in a full-time academic faculty position. I get the exciting task of kind of teaching some of our young minds at the entry level some thoughts about orthopedic manual therapy and orthopedic physical therapy in general. I'm still involved in clinical practice about 8 hours a week, and a good chunk of that I'm also spending working as a mentor within an orthopedic residency program.
So you definitely have your hands in a variety of things at this point to keep you sharp. If you can give us a little bit of information on the background of your current study, what prompted you to delve into this specific line of material?
Sure. One of the things that we'll find is if we look at all of the different schools of thought of manual therapy, the vast majority have some variety of test or measure that's proposed to help differentiate the region of pain or the region that may contain the pain generating structures. I think particularly when we talk about the cervicothoracic spine, it's an area that is discussed a lot when you look at the orthopedic manual therapy continuing education side of things, when you look at the residencies and fellowships, but really there was no evidence discussing the use of the tests. As a profession, we seem to have gone the direction of saying that thoracic manipulation is good for everybody. It's like green leafy vegetables, and if you have somebody with neck pain, if they get a thoracic manip, they're going to get better. Much like you eat your broccoli, and it's going to help you some way with your health. Concurrently, we also know that there's a fair number of people that either won't respond well to manipulation or, from a risk benefit standpoint, have issues in their comorbidities that might preclude us from wanting to do a thoracic manipulation. And so, an understanding of really who might respond best or who might demonstrate the most improvement following a manipulation, is really a intriguing piece of the puzzle to try to investigate. And from a clinical experience standpoint, we've certainly seen that the regionalization tests seemed to be demonstrative of people who would be most likely to improve following a manipulation. And so it kind of looked like, not to call it low-hanging fruit, but one of the really obvious questions in need of answer.
Absolutely, and that would help just streamline people's treatments, hopefully getting to the idea of becoming more efficient and reducing the amount of time if we can better hone who needs what intervention. Can you describe for us what the tests were, the differentiation tests that were the hallmark of the study?
Sure. We looked at 3 separate test measures or really constructs to try to decide who is going to improve following manipulation. And so the first, we looked at the provocation alleviation schema that was proposed by Olaf Evianth and was described in his short book on provocation alleviation testing. And so the test there essentially involved asking our participants or our folks who had neck pain to move into their most provocative position, whatever that may be. So cervical flexion, extension, side bend, rotation, establishing their baseline level of pain with motion, and then positioning their thoracic spine in a position that was opposite the cervical provocative motion. So we tried to do essentially a counter movement that was maintained by the therapist. So as an example, if somebody had their most pain provocation with right cervical rotation, we would ask them to perform a left trunk rotation, so prepositioning the thoracic spine in a left rotation. That position would be maintained by the therapist, and then we'd ask the patient or the participant to repeat their right cervical rotation and see if that changed their pain. And what we were looking for was an alleviation where they said, yes, that feels better, or they demonstrated significantly greater range of motion than they'd had previously with the reproduction of similar pain happening later in the range. We looked at that as being indicative, saying there's the possibility that the pain generating structure would then lie within the thoracic spine. The other pieces that we try to look at with it, there's been some proposals for regional unloading procedures, which on a construct basis should influence the behavior of the facet joints if it's possibly facet mediated pain. And so we looked at unloading the cervical spine. That was delivered with a vertical force applied through the occiput. What we know about that is lifting up on the cervical spine, we believe to unload both the cervical and thoracic spine. And then to try to tweeze that out a little bit, we also tried a thoracic unloading to see if that would regionally influence the segments of the thoracic spine without influencing the cervical. And so we took those 3 tests and the results of each on a simple dichotomous yes, no. They felt better with that test. They didn't feel better with that test. To then go back through and see how that aligned with their improvement post single session of manipulation.
To clarify that I do indeed understand how they were actually performed. On the unloading tests, it was straight axial distraction in neutral, or was it done at the point of where they got their pain?
That depended on where the subject or participant had their pain. So if a participant had their pain in neutral, we would perform the test in neutral. If the participant only had their pain with motion, we would perform it in the position where they had their pain.
Perfect. Thank you for clarifying. Cervical thoracic differential testing that you described first, where let's say they had pain in right rotation, you'd take them, let them go into the point of their pain in right rotation, and then essentially created a caudal rotation as they turned their trunk and shoulders back to the left. Do I have that visualized correctly?
Essentially, yeah, just to make sure we're on the same page kind of temporally. We'd ask them to rotate to the point of their pain. We'd assess where that was, and we'd ask them to record how much pain they had. We would then ask them to come back to a neutral position, caudally counter-rotate the segments through the trunk, and then repeat the cervical rotation with the caudal segments pre-positioned counter.
Great. I just wanted to make sure that we had a good description because on audio, you don't have the benefit of the pictures. The pictures you have are perfect. They show it well. And a link to your study will be in the show notes.
Fantastic.
We probably need to get a little bit of information out there on who was included in the study and who was not included in the study. Can you tell us a little bit about your exclusion criteria?
To be included in the study, our participants had to be between the ages of 18 and 60 with a primary complaint of neck pain that was at least 3 out of 10, which would help us prevent any floor effects or any limitations in improvement that might skew our statistical analysis. And then we excluded anybody who had signs suggestive of a non-musculoskeletal pathology. We excluded anybody with signs of radiculopathy. We excluded recent whiplash. We excluded anybody who had a history of prolonged corticosteroid use, osteoporosis, potential bony pathology, anybody that had central cord signs. Yeah, because really we wanted to make sure that they would be consistent with the group that we should be considering for thoracic manipulation, at least as the neck pain category. And we excluded the radiculopathy folks specifically because we were looking for change in axial pain with movement. We felt that the radiculopathy folks may have changes in their distal symptoms. However, it wouldn't match up with our construct for how we were assessing their pain.
That makes a lot of sense. Did you have any thoughts or hypotheses on what was actually occurring with these tests? And did you consider what tissue you might be affecting? I'm just wondering if you had any thoughts on what was the mechanism behind the pain relief.
Well, from a theoretical standpoint, I think it's very enticing to want to say that it's a biomechanical effect, and if we eliminated motion caudally and saw a change in pain, that at least we could say that the symptom generating tissue would be one of the caudal tissues. From a specific, pathological standpoint, pathoanatomical, I think, we all need to be very careful about saying, yes, it was just the facets, or it was just the disc, or it was just the soft tissues, wherever the case may be, because we know that manipulation has very broad and somewhat overlapping neurophysiologic effects that can really influence what we're seeing. And it really just became the question of, are there individuals who respond more strongly to a regional stimulus than others? Do they demonstrate a greater improvement when we apply a thoracic manipulation if they show us that we're able to moderate their symptoms by changing the stresses on their thoracic spine? And I think really what we're able to start to take out of this study is that, at the very least, regionalization is a useful thought process for us, as much as we may not be able to ever say a specific pathoanatomic tissue.
Thank you. I enjoy the discussion on hypotheses of what's happening. That big overarching neurophysiological influence that we've found is a big component of manual therapy and modulating pain and improving motor recruitment. Also, the idea that there's a lot going on, so it's hard to pigeonhole it into one specific process.
Absolutely.
Can you give us a little bit more about the actual methods of the study and how the study was laid out?
After our screening for inclusion-exclusion and the obvious informed consent process, we had our participants complete an NDI, which we used purely as a measure to make sure that our groups at the end had similar levels of disability and we weren't missing some other construct that may be biasing the result, which fortunately, as far as NDI scores, there was no difference between our groups at the end. We asked them to then come in. We looked at their cervical range of motion, obviously. We did a quick myotomal dermatomal screen to make sure that they didn't have any signs of radiculopathy that we needed to exclude. And at that point, we jumped straight into our differentiation testing. And so we looked at our cervical unloading, thoracic unloading, and the cervical thoracic differentiation tests. And again, dichotomized those into positive and negative results. Once we completed that phase, the investigator that the participant was working with that day would identify what they determined to be either the most hypomobile or most painful segment in the upper thoracic spine. So based on some of the previous biomechanical literature, we consider upper thoracic to be T1 to T4. And so we picked a level in that region. All the participants then received a single supine thrust manipulation to the investigator identified level. Then let the participants rest for a moment before we had them resume the seated position. We asked them to repeat their provocative motion, where we again took a look at their range of motion and asked them to assess their level of pain using a visual analog scale. So if we had the immediate pre-post for their pain.
And you had 48 participants in this study, correct?
Yes, we did.
Everybody got the same thoracic manip, and you had that as described by Cleland and Cross. So you had references for the manipulation performed. You had 3 facilities performing the study, correct?
Yes, so we collected the data at 3 different facilities. So we had 2 outpatient clinics, one in Scarborough, Maine, one down in Guilford, Connecticut. And then we also recruited subjects from our graduate health sciences campus up at the University of New England up in Portland, Maine.
All right. And all of the therapists performing the tests and the manipulation had minimum 10 years experience. And were they also fellows?
Yes, so every therapist that performed the interventions was fellowship trained as well.
Getting into the results and the data analysis, can you give us the take home message of the results?
Sure. For the actual results of the study, what we found that the individuals who had a positive cervicothoracic differentiation test were much more likely to demonstrate improvement than the individuals who had a negative cervicothoracic differentiation test. Well, we're not able to distinctly say that it is as the result of the intervention or as the best intervention for these folks. What we know is that the individuals who had a positive cervicothoracic differentiation test demonstrated a much higher overall level of pain relief. Yeah, the mean in that group was over 30 millimeters on the VAS, which was very substantial. The folks that had a negative differentiation test were hanging out in the 17 millimeter range, which as an overall result is still useful, but certainly not as substantial as those in the positive group. And so if we look at it from a diagnostic test accuracy standpoint, really what we found was that the cervicothoracic differentiation test by itself really performed very well as a test. Whether we looked at it for a threshold of improvement of 15 millimeters on the VAS that's been suggested as the MCID, and also at the 50% threshold. So what we saw was that individuals with a positive cervicothoracic differentiation test, in and of itself, the test had a specificity of 0.88, so it significantly identified the individuals who were going to improve following manipulation. And so as a standalone test, if we looked at the differentiation test versus the cervical or thoracic unloading, the cervicothoracic differentiation test was the only one that really gave us really high levels of specificity as well as positive likelihood ratios to identify the potential improvement. So the likelihood ratio was actually the positive ratio was 6.23. If we're going to look at it just for minimally clinically important difference in pain following the test, and so the differentiation test by itself certainly stood out. As we looked through the data, the cervical unloading and the thoracic unloading, well, they weren't very specific in telling us who was going to improve. They actually had higher levels of sensitivity, and so the folks who had negative unloading, we thought, well, maybe those are the folks who won't improve. We tried to put the test together into a battery, but what we found when we looked at the different batteries of tests, there was really no benefit of trying to add the additional tests to the cervicothoracic differentiation. And that really became our best single measure to say, yes, this individual is going to improve significantly following manipulation.
You have some really nice graphs where you laid out your results for the different tests, and those would probably be helpful to put in the show notes. That visual helped me process all of the information because there's quite a bit of information with 3 different tests and different scenarios.
Yeah, the manuscript right now is a little thick, so probably the visual will be nice to include there to whittle that down a little.
You did a good job of discussing the results. Can you put this into a synopsis of what's the clinical take-home message of this study? If you're in the clinic with your patient, how is this results or this study helpful?
Sure. I think to put it in the clinical perspective, and again, it comes back to really the genesis of the study for me. Why do we look at a test to try to determine who will improve following manipulation? What we know from the data that's out there, at least from the previously reported prevalence of improvement after thoracic manipulation was 54%, which is essentially a coin toss. Our overall prevalence in this study was higher. We saw meaningful shifts in the result based on cervicothoracic test results. And I think if we have any uncertainty in terms of relative value of a thoracic manipulation for our patients, the ability to at least discern, yes, they're much more likely to improve, or no, they're not so likely to improve, is a really useful clinical tool. And I think it helps us explain to our patients why we're going to apply the interventions as well. I think orthopedic manual therapy, and particularly when you get into the realm of high velocity thrust, there's a great deal of trust involved in the patient provider relationship. And I think being able to accurately say to them, yes, I have a tool, I have a technique that should help me identify that this really should be good for you, particularly in the presence of any comorbidities. It can be very, very helpful.
Yeah, I actually hadn't thought about that, but that would absolutely enhance that therapeutic alliance. We know the biopsychosocial side of that relationship with your clinician actually does feed into outcomes and results. So that's a great point.
If we were going to link it to some of the other work that's out there, one of the previous thoracic manipulation studies that we had worked on, really showed that based on the message that you told your patient, you could change their perception and change their view as to whether or not it's going to help. I think being able to honestly say to them, yes, I think this is going to help and here's why, really helps set the stage for that. Now, that in and of itself is a totally separate research question and one that we didn't answer here. I think within that, we need to, again, throw the caveat that there are some limitations to this study. It was a relatively small sample. There was no control group. There was no comparative intervention. So we can't say that this one intervention is necessarily the best for these folks. We can just merely say that, yeah, it seems to really identify someone who's going to respond well. But I think putting that in the context of therapeutic alliance, putting that in the context of clinical decision making and clinical judgment can really be a helpful piece for the practicing clinician.
Very well stated. This was just a single retest on their symptomatic provocative motion. There was not a follow up. Am I correct?
There was no follow-up outside the immediate term. We also can't say that these folks are going to have lasting improvement. We can't say that changes in function. Those, again, are kind of the follow-up research questions that'll probably keep several of us busy for the next few years. I think it's a nice springboard into some clinical reasoning in the thoracic manipulation realm.
Now, have you worked on expanding this study at all yet? Or are you just working on getting this one published?
Yeah, right now it's finish paper number one before we start project number two, but that is definitely on my to-do list and in the future, my future research plan to try to expand this on a larger clinical scale, particularly with some comparators and probably a control group.
I would look forward to reading that paper in the future as well. Is there anything that you are currently working on research wise in addition to this?
My current research right now is actually looking at the effects of glenohumeral mobilization. That was a grant-funded project through the Academy last year, and so we're in the final stages, looking at the interactions between oscillatory and sustained mobilizations of the glenohumeral joint relative to changes in translation in the shoulder itself, rotator cuff activity during mobilization, and measures of pain processing.
Congratulations on receiving that grant. That was the Cardon grant, correct?
That was. Thank you very much. Yeah, hopefully that one will be on its way out soon. The worst case scenario, you will see some results at the 2019 AMP conference.
Excellent. That'll come sooner than you think. Brian, can you give us some insight and maybe some advice for people who are either interested in pursuing a fellowship and or interested in getting involved in a research track? How would they go about doing that, and perhaps what's the benefit of doing that?
Sure. I think I'll address the fellowship side first, because I think fellowship is probably one of the most valuable clinical experiences that somebody can pursue. The opportunity to align yourself on a long-term basis with a knowledgeable mentor who's really just interested in helping you improve as a professional and as a clinician and improve your judgment, and to be there as a resource and to kind of really show you the way that our profession has grown and where you can grow within it. I think the fellowship experience is one that I really wish more young clinicians would consider pursuing. We see a lot of our younger clinicians and newer grads saying, well, which clin ed should I take? Which weekend seminar should I take? And I think really what we need to be directing them towards is which long-term structured growth opportunity should I be pursuing? I think both the residency process and the fellowship process are tremendous growth opportunities for young clinicians. Really, we need to continue to strive to make more accessible for them, emphasize earlier in their careers that would be a way to go. From the research side, deciding that you want to pursue your own independent research questions, generally speaking, that's deciding that you're going to make the commitment to a post-professional degree program, because I think that's really where the best mentoring is going to live there and the best structure to educate you how to do that well. I don't think that completely excludes the practitioner who says, hey, I have this question from from pursuing research. I think the Academy and the Academy's research committee in particular would love to hear from those individuals to say, I don't have a terminal degree, but I have this research question. I'd love to answer it. Can you help align me with experienced researchers who can help guide me through this process? And I think that's an area that as an academy, I don't know if we emphasize that enough. And if we really go out there to the practicing clinicians and say, yes, we'd love to help you answer your questions. Because I think as orthopedic manual therapists, a lot of our really meaningful questions really reside in the clinic. And it's the people seeing patients every day who probably have the most meaningful, most relevant questions, as opposed to those of us who are in the academic side that sometimes when you're not in the clinic full time, you don't see as many patients, so you don't have as many relevant clinical questions in your head. And I think sometimes we go down some very theoretical pathways that don't necessarily relate to the clinician. Good clinical research, for assuming it's going to be a lot of the folks who are listening to this podcast, that's really the direction that we could pursue.
Brian, thank you so much for joining me today. It was truly a pleasure to chat with you and get more of your wisdom and insight. I really look forward to meeting you and seeing you at the American Academy Conference coming up. And I wish you the best of luck in your research. And we are so appreciative of all that you are doing for our profession in getting behind the research and digging in and doing some of the hard work.
Thank you for having me, and thank you for allowing me to share my research.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.